Welcome back to the Anatomy Lab podcast. I'm Dr. Khan, and I am absolutely pumped today because we are diving into something you can actually feel and see in every single patient encounter: muscle tone and atrophy. It is the hum of the human machine.
It certainly is, Dr. Khan. And while you're excited about the hum, I'm focused on the mechanics. For our students listening, today's topic is a frequent flyer on Step 1 and Step 2 exams. We are moving beyond the names of muscles and into how they actually behave in a clinical setting.
Exactly. So, Sarah, let's start with the basics. Muscle tone. When I'm in the clinic, I think of muscle tone like an idling car engine. Even when the car isn't moving, the engine is vibrating. There's a baseline level of activity. In a muscle, even at rest, there's this slight tension, right?
That's a perfect analogy. Technically, muscle tone is the involuntary resistance to passive stretch. As an educator, I have to emphasize that this tone is maintained by a reflex arc. You have afferent signals coming from the muscle spindles and efferent signals going back to the fibers. If you break any part of that circle, the idle stops.
And that leads us to our first clinical state, flaccidity. Why does this matter clinically? Well, if I pick up a patient's arm and it feels like a wet noodle, zero resistance, just heavy and limp, that tells me something is broken in that reflex arc.
Right. High yield point here. Flaccidity, or hypotonia, is the hallmark of a lower motor neuron lesion. Think of conditions like poliomyelitis, which attacks the anterior horn cells, or a traumatic injury where a nerve trunk is completely severed. No signal, no tone.
It's like the power line to the house is cut. No matter how much you flip the switch, the lights aren't coming on. But what about the opposite? What if the idle is set way too high? We call that hypertonia.
Hypertonia is where the resistance to passive movement is increased. This usually points to an upper motor neuron lesion, something happening in the brain or the spinal cord. Without the higher level boss in the brain to tell the spinal cord to chill out, the reflex arc goes into overdrive.
I see this in stroke patients all the time. The muscles are tight, almost fighting you when you try to move the limb. It's a huge clue for localizing where the damage is in the nervous system. But Sarah, let's talk about the visual side of this: atrophy, the use it or lose it principle.
Atrophy is the wasting away or decrease in the size of the muscle. Clinically, we see this in two main ways. The first is disuse atrophy. Think of a patient who has their leg immobilized in a cast for 6 weeks. Because the muscle isn't being loaded, it shrinks.
And the second is denervation atrophy, which is much more aggressive. If the nerve is gone, the muscle doesn't just get smaller, it practically disappears. It's like a garden without water. Why does this matter clinically? Because if I see a patient with massive wasting in just one specific area, I'm not thinking they just skipped leg day. I'm looking for a nerve entrapment or a lesion.
Precisely. And for the boards, you must be able to distinguish between the two. Disuse atrophy is slower and can be reversed with physical therapy. Denervation atrophy happens much faster and is often accompanied by those wet noodle flaccid signs we discussed.
You know, when a patient is looking for their doctor of choice, they want someone who can spot these subtle changes in symmetry. I always tell my students to compare the left side to the right side. If the right calf is half the size of the left, you've got a major red flag.
Speaking of red flags, let's talk about segmental innervation and reflexes. This is bread and butter board material. To test if the muscle and its nerve supply are healthy, we use tendon reflexes. Dr. Khan, give us a clinical rundown of the big ones.
Oh, I love these. They are like the diagnostic cheat codes. Tapping the biceps tendon tests C5 and C6. Tapping the triceps, that's C6 to C8. Moving down to the lower limb, the knee jerk or patella reflex is L2 to L4. And the ankle jerk at the Achilles, that's S1 and S2. If those aren't firing, you've got a localized problem.
And remember, if those reflexes are hyperreactive, meaning the leg kicks like a mule with just a tiny tap, that's often that upper motor neuron issue again. The brain isn't there to dampen the response.
It all comes back to that balance. We also need to mention Hilton's law. It sounds fancy, but it's so practical. The nerve that supplies a joint also supplies the muscles that move that joint and the skin covering those muscles. So if a patient has a funky, painful knee, their quadriceps might show altered tone because they share the same nerve family.
That is a great point for clinical diagnosis. If the in-joint is inflamed, the body often increases muscle tone around it to splint the joint and prevent further damage. It's a protective mechanism we see in everything from a sprained ankle to abdominal guarding and peritonitis.
So to wrap this up, why does all of this matter clinically? Because the muscle is the end organ teller of the nervous system story. If you understand tone and atrophy, you can figure out if the problem is in the brain, the spinal cord, or the peripheral nerve just by using your hands and a reflex hammer.
Well said. The big takeaways: flaccidity and rapid atrophy equal lower motor neuron lesions. Hypertonia and exaggerated reflexes equal upper motor neuron lesions. And always compare both sides of the body to catch atrophy early. Boom. Anatomy in action. Thanks for joining us today. Keep your idle steady and your reflexes sharp. We'll see you in the next episode.